You would have thunk after doing this all day yesterday, I would have gotten the hang of that, but obviously not. Okay, so I am excited to introduce the next speaker. Philip Austin is a postdoctoral research fellow and practicing osteopath who holds a PhD in pain medicine. Oh, I see you frozen. There we go. Phil's research interests include the analgesic effects of virtual reality experiences in people with spinal cord injury and cancer pain, and the assessment of endogenous pain modulation in people with chronic pain conditions. Phil's clinical areas of interest include the effects of work-related stress on the severity and duration of musculoskeletal pain. Phil also works as an academic tutor for the master's postgraduate degree program in pain management at the University of Sydney and is visiting fellow at Victoria University. So that covers actually quite a lot of area: work-related, stress, spinal cord injuries, chronic pain. This is actually a time where other speakers have done show and tell, but I understand you're at work.
Yes.
So
it's about 6 o'clock in the morning.
Oh, so also not much. That's very early to be at work. But I guess I would be curious, working in virtual reality, do you have any favorite virtual reality studies or experiments that you've done looking at a chronic pain condition?
I think with the spinal cord injury patients, it was really good because we had them in well, everything we did was commercially based. It was all affordable. So if they enjoyed it, they could actually go out and purchase if they liked. And many of them, it was the first time they'd moved out of a wheelchair virtually for maybe 20, 30 years. So it was a real experience for quite a lot of them, which was a bit of a surprise to us. And I think out of the 16 people in the pilot study, about 9 or 10 purchased the virtual reality headsets and use them on a regular basis, not just for pain relief, but just for stress relief more than anything else, to kill time. And then with the cancer patients, because we're working with end of life for the majority, we're using a NatureTrex application, and for a lot of them, it reminds them of being back at home as a child, and that at the end of life is really important, and it evokes quite a lot of strong memories and emotions. Again, something we didn't, we thought about it, but we didn't think it would have such a strong effect.
So was the intent on that to address pain that often comes along with cancer, or just kind of the general well-being of the person?
Well, we're just looking at primarily looking at the effects on cancer-related pain, whether it's due to the cancer itself or the treatment of cancer, and then the residual effects of cancer in cancer survivors, which is probably going to be our next study, really.
Oh gosh, that would be fascinating. And I'll confess to not having read any of your work, but after even just reading the intro, I'm very excited to read more, because the bits and pieces that I have read about virtual reality is very, well, to be honest, it's fun. It's something that's not like the usual PT or the usual treatment. And like you said, the idea of being able to do it at home and having fun doing it is really attractive.
Yeah, I mean, I use it. If I've got to set up for a participant, I find I use it myself before they come in, and just because I quite enjoy it. It's quite relaxing.
That is awesome. I'll confess, I've also never done virtual reality. I grew up without video games, and I haven't gone down that road yet. But
Well,
now
so did I until I started doing the research. That's what I like.
Really?
Yeah, I was never interested in video games.
So with the virtual reality, because we have one more minute, what is it like? Is it a game, or is it just experiencing a virtual world?
Because we're doing a one visit only, any form of game, people will pick it up faster than other people, so it wouldn't be a level playing field. So we've just got a very simple NatureTrex with the aid of a joystick. They can move around, and there's no interaction, but they can look at animals and mammals, birds, fish, ducks, and they can just wander around this really nice sort of dawn meadow experience, and they have it for about 15 minutes. And I'm not going to give too much away because the rest of it is in the presentation.
So that was a beautiful segue. I'm going to let the magic happen and the lecture to play, and then we will see everyone back here afterwards for some questions and answers.
Okay, see you soon. Hi everybody, my name is Phil Austin. Before I start, I'd like to say many thanks to Rajan for inviting me along to talk at this autumn edition of the San Diego Pain Summit that should have been in North Carolina. And today I'm going to be doing a presentation on the effects of virtual reality on people with several different types of chronic pain condition. Before I start looking at the virtual reality, I'm just going to do a 2 or 3 slide overview of the mechanisms of chronic pain. So when we come to talk about the virtual reality, you'll have a better understanding of how the virtual reality actually works. So just to get going, I'd first of all like to look at the features of chronic pain, what chronic pain looks like when people come in to your clinic room. Now, before I go into the features, I'd just like to sort of just talk about how in healthcare, a lot of practitioners still consider the mechanisms of chronic pain to be a persistent version of acute pain. And this is where people believe that peripheral inputs they consider them to be the main drivers. So tissue damage is a good example for a person's pain perception. So for example, a clinician may prescribe non-steroidal anti-inflammatories to reduce localized peripheral inflammation. They might recommend passive therapies such as manual therapies or rest from the exercise or the thing that they think that's causing the problem. And this is not very beneficial for people with chronic pain. And because of this, there's quite a lot of frustrations, not only for the patients, but also for clinicians, where the sort of beliefs towards chronic management end in frustration. So while pain can often be maintained by peripheral mechanisms, i.e. for people who do sport and they keep insulting a particular joint or set of joints or tissues, the most difficult to approach is that of chronic pain, which is being centrally driven, i.e. the spinal cord and the brain. So what are the features? So first of all, there is no obvious link when people present between the reported pain intensity or severity and the level of pathology or dysfunction. And this is because the pain is not being driven from these tissues, it's actually being driven from a different place. So the characteristics of centrally mediated pain, and this is really quite important for people who have to make a decision on their management plan for patients, is that people with centrally mediated pain, the pain tends to be widespread. It's quite diffuse. It's very difficult for a patient to say, my pain feels it's right on that spot. They tend to cover a large area when they're talking about their pain. And it's very hard to pinpoint. Pain is often triggered by things that are not normally painful. And this is a classic term known as allodynia. Their pain is really unpredictable. They don't know when it's going to come on. And this tends to make the patient guard and become very protective of themselves in every situation. It's almost like it's got a life of its own, and this is known as spontaneous pain. There are other features which are not related to pain as such, but other sensitivities, so sensitivity to light, to sound, to touch. There is nearly always alterations in mood, sadness, anxiety, depression. They don't sleep very well, and this is not only because they have pain during the night, but also because they're anxious about the pain and they can't stop thinking about it. And because of that, they're unrefreshed and they have poor concentration and fatigue during the day. And it is this really that these are the classic features of people who present with chronic pain. So if we take a look at sort of a more light-hearted look at how chronic pain evolves, and these are, well, the depictions of the images done by Descartes. And the first image on the left is sort of shows a typical nociceptive response. So the boy, for whatever reason, puts his hand in the fire. And in the words of Descartes, the particles of heat activate spots in the skin, and these spots are attached to fine threads which go all the way to the brain. the inputs going up this fine thread then open a valve, and once the valve is opened, the person perceives the pain coming from the flame. When the person takes the hand away from the flame, then the pain stops because the inputs have stopped coming up. And that is a classic acute nociceptive pain response. However, if the person leaves their hand in the flame a little bit longer than they should do for whatever reason, these increased inputs or prolonged inputs tend to sensitize the skin at the periphery or the tissues at the periphery, and the repeated inputs from that peripheral injury then sensitize mechanisms in the dorsal horn, so you get increased activation of the synapses there, and then that increases the level of inputs going up to the brain. And again, the same thing happens there, where it takes less to stimulate a pain response. So not only does it become amplified in intensity or severity, but it also becomes more and more unpleasant. And the more unpleasant or the more horrible or the more awful it becomes, the more the limbic system structures tend to be activated and sensitized as well. And to take this a stage further, if it keeps going, then people tend to avoid work, avoid social activities. Significant others tend to take over their roles, so they become less active, and they tend to sort of atrophy, if you like, and they become less conditioned and less able to tolerate daily life activities. Okay, so they tend to get rather emotional. Their cognitive understanding of what's going on changes, and their behavioral responses as a response change as well. So they become very fearful. They catastrophize about their pain being due to the worst possible scenario. They avoid activity, and they become hypervigilant on their symptoms. And this is all they think about. So if we look at a schematic diagram of what switches on pain and what switches off, and this is something that we give to patients on the hospital pain programs, and this is a sort of jazzed up version, if you like, of Marchak and Wall's pain gate theory. So if inputs become prolonged, the gates at the periphery, at the dorsal horn, and in the brain remain open, and the neuromatrix or the pain neuromatrix becomes more easily stimulated with less stimulus, where ascending inputs, the blue lines along the pathways to the sensory cortices and the limbic subcortices, it's very difficult for the gates to close and the pain to stop. So things that open the gates are repeated noxious inputs, anxiety, fear, and stress, a lack of control, hypervigilance, a lack of sleep, and poor previous pain experiences. So if they've had this pain before and it's been a really awful time for them, this will have a negative effect on what's happening at the here and now. And because we recognize these gate openers, we can use a pain education to try and get people to self-manage and to close the gate themselves. So if we look at the gate closers on the top right, we can see that pain education is really helpful in getting them to understand what's driving their pain. And this means they can start taking control of their own rehabilitation, if you like, getting themselves stronger to cope with the demand of daily life, relaxation and distraction, and this is where virtual reality comes in, also helps to take focus away from the pain, reassure the patient that everything's going to be all right, there's no significant damage, it's just that everything's a little bit sensitive and we really need to desensitize. And that involves the clinician and the patient to work together. And for that reason, it's good for the clinician to give the participant, or the patient, sorry, known positive outcomes on how most people who do this type of stuff get better in the long term. So with that, it's time to move on to the virtual reality. And with the virtual reality, what I'm going to talk mostly about is how distraction really helps taking the focus away from a person's pain onto something that's completely different. And because they understand that the pain can be controlled, this can be a starter for people to really move on with their pain. So what is it that makes virtual reality so unique? It's immersive. It's having the perception of being physically present in a non-physical world. Embodiment. We have a self-representation within this virtual world. If you look at the second image, the middle image, we can see representation of the person's hand within the virtual environment. When they use their joysticks, they can make their hands move within that virtual world, and they can touch things, they can pick things up. So it involves vision, touch, proprioception, motor control. All of these factors are often compromised in people with chronic pain. And because of this, and I'll just move my figure along a little bit, we can see that once the person interacts, they become engaged within this virtual world, and it's this engagement or this level of presence which really helps to distract a person away from pain. So if we look at virtual reality stimulation, how does it work? Well, it's this perception, as I said before, about being physically present, being immersed in a different world. So basically, VR is a computer-generated simulation of a 3D environment that can be interacted with by the person in that world in a seemingly real physical way, using specialized electronic equipment. And the elements of VR that increase this level of immersiveness is wherever you look inside the world, and it tends to be about 270 degrees because you haven't got the head of an owl, you feel like you're actually there. So wherever you look, you are in that environment. It's compliant with human vision as well. So the area of central focus tends to be really detailed. As you move out towards the periphery from central vision, it becomes less detailed. There's a freedom of movement. So if we look at the top image, this is a still taken from a set of virtual reality applications that we're using for some studies, and this is called nature treks. So the person with a joystick or an Xbox console can move around this virtual world, and this is an alpine meadow. There are jungles, there are deserts, there are beaches. The participants can choose the one they want to watch, and they can look at animals moving around, birds and fish and butterflies and insects and what have you. So although they can't interact, they can observe and move around, and it's really good for relaxation. And in with this are naturistic noises as well, if you like. In other virtual reality applications, there's a lot more physical interaction. So if you look at the middle image, this is something called Home by the BBC, and this involves a spacewalk where they have to open hatches within the space station, move out onto what's called a Canadarm. They have to be able to manipulate tools and get good at virtual repairs of solar panels that are being damaged by asteroids on that space station. And that takes a bit of practice. So the work we've been doing involves a one-off consult where the participant comes in and we look at the effects of virtual reality on chronic pain between 3D fully immersive in headsets or on a computer screen. So we're just looking at the levels of distraction, if you like. If you were going to look at something more long-term, they would probably get a little bit bored with that, and they need something a bit more interactive, and they need to just sort of have a virtual reality application that helps develop skills. And this is where this moonwalk or this spacewalk type of thing comes in. And there's also physical feedback. So with new haptic technology, where you can have these data gloves or with joysticks, you can get a certain amount of sense when you touch things. You can get a sense of vibration, or you can get a knockback sensation onto your gloves, onto the joystick, from the thing you've touched in that virtual world. So we come to look at virtual reality hardware. What do we use to get this simulated 3D environment? We have, if you look at the top, we have these 3D enabled glasses within this headset. And here you can see the joysticks, and this is an Oculus Rift headset or an Oculus Quest. The Oculus Rift was the older version, which we are still using because we want to use the computer screen as well. So we have to use a gaming laptop to run the software. But now the new Oculus Quest has all of the hardware within the helmet, so you don't need any other computer equipment to run it, which is great for future studies where we can give the people something quite small to use at home, and they don't have to set up sensors and what have you. What we found quite probably the most important for the level of immersion or level of presence, is the noise cancelling ability of these headsets. So when they put the headsets on, the noise cancelling distracts them from what's going on outside. And if you work in a hospital or in a clinic, next to a busy road or next to a set of gardeners in the hospital grounds, this we thought was going to be a real big problem, or people talking in clinic rooms in the next door. But these noise cancelling headphones have really put a stop to all that, and it's something we haven't had to worry about. Moving on, we've got head and body tracking. And if you look at the two middle pictures here, we can see hands, virtual hands, working in the helicopter, on the virtual helicopter, and the bottom, and the hands and the head are tracked and able to move the helicopter around, and the ability to move and play with the helicopter instruments. I'll just move myself along again. Finally, we have augmented reality. And this is the, if you look at the bottom left, this is the Microsoft HoloLens 2. So you put the glasses on and you look, you are within your normal environment. But within that normal environment, you can have virtual objects which you can manipulate, play with, move into, and this is quite a strange feeling. I've only done it a few times. We have a few sets up at one of the medical institutes in Sydney. And even though it's in its infancy, it's got the potential to be really worthwhile in a number of different, well, medical settings, for example, such as surgery and medical training. So I'll move myself back here for the next slide. Okay. So how do the mechanisms work? So the mechanisms through which VR distraction operate, and I've sort of touched on this before, as explained through the neuromatrix theory of pain. And this is where increased cognitive activity of being within this virtual environment inhibits the transmission of pain signals from the periphery up to the brain. Or the distraction takes the focus away from the pain that's being perceived, that's being driven by the central nervous system. And it's not just a perception of pain that it gets rid of or reduces, but also levels of stress. And this is really because in cognition, attentional resources are limited, and sensory distraction leaves fewer resources in the brain for pain processing. And it's this that is thought to incorporate different sensory modalities of the virtual reality, and it offers less opportunity for the person to appreciate, for want of a better word, their pain. Moving on to the next slide. So let's talk more about clinical applications. How can it help us in the medical world? Well, of course, I'm talking about pain, so I'm gonna leave that one for the time being. It's also really helpful for people with mood disorders, and this is especially good with the stuff we were using, these nature tracks. There's also a lot of mindfulness applications and meditation applications, which have been shown to work really well in people with mood disorders or chronic pain, and where the mood is the main driver of their chronic pain. It's also being used quite a lot, and even more so now in rehabilitation. So for strength, where we have virtual, we have to copy virtual people doing exercises, and you get given a task, endurance and proprioceptive applications as well. And this is for the case of people with, for a good example, chemotherapy-induced peripheral neuropathies, where they get retrained in rehabilitation in walking and balance and what have you. Another useful area is phobias and PTSDs. And if you look at the middle one, the middle left, there's a arachnophobic phobia type application, and this is called Fearless, and this was developed by a guy who had terrible fear of spiders, and he spent hours and hours and hours in this virtual world of spiders, playing with them, manipulating them, holding them, letting them crawl on his hand. And in the end, he became so used to this that when he came to, he was actually able to then play with real spiders. And there's some images of him on the web, of him with dirty big tarantulas crawling all over his skin, and he's got a big smile on his face. Clinical skills I've touched on before. Augmented reality and virtual reality have now been used for surgery from distance. And it's also good for surgical training. Again, if I just move my body over to the left, we can see here the application of augmented reality on the training for surgical procedures as well. And also clinical skills. Clinical skills has become really quite useful. And not forgetting in here that you have these haptic technology that gives you the feedback when you're pressing on different tissues, the density of different tissues when you move through tissues as well within this surgical training element. And this has been shown to be really useful. Okay. So let's look at the short term in a bit more detail, the distractive effect. So what we're really talking about is an advanced form of imagery that induces experience and emotions. So when you have your repeated noxious stimuli going up into the brain, we have our intensity, our location, and the character of pain that's perceived in the somatosensory cortex. And we have the fear and the anxiety and the misunderstanding of pain in the limbic system, the anterior cingulate cortex, parts of the prefrontal cortex, insular cortex, etc. So by bombarding this area with more pleasant images, and I've put a cheeky little beach number on there with some nice music, this is a temporary distraction from the problems that they perceive. And certainly in people that we've been working on, namely people with spinal cord injury, where they're riddled with a lot of neuropathic pain, they've loved it, and they've gone out and bought these headsets because of it doesn't replace medication, but it's very good for complementing the medication, if you like. So really what we're talking about is the alteration or temporary alterations in excitability of neurons in pain modulatory pathways. So you're inhibiting pain facilitatory pathways from the brain down, and you're exciting neurons that run along the descending pain inhibitory pain pathways. So just a couple of examples. This is something done, I think it was in 2014, and this was done in people who don't have pain. These were healthy participants. And what they did is they used a 30-second heat stimulus that was painful, but not painful enough for them to tell the person to stop. And they showed significant reductions in pain facilitatory regions of the brain. And this was measured using functional magnetic imaging in the anterior cingulate cortex. So if you look at the top, we can see with no virtual reality, there was significant stimulation of the anterior cingulate cortex compared to VR. The primary somatosensory cortex, again, that's very similar, but that's because you're stimulating pain pathways. Quite a lot of difference in the secondary somatosensory cortex. I'll move myself along a bit. Now, if we look at the insular, huge differences. There's a lot of increased activity here with no VR and hardly anything here. And of course, the thalamus, which is sort of the gateway to all of the different parts of the limbic system in the somatosensory cortex. So here what they found was there was about a 45% decrease in the unpleasantness of pain, or the emotional aspect of pain. There was a nearly 45% reduction in how much they thought about pain when they were using the VR compared to no VR. And there was about a 30% decrease in pain intensity ratings compared to no VR. So this was really the first study, if you like, to show objectively the brain regions that are activated or inhibited, if you like, by the use of virtual reality. Moving on further to a study that was done a little bit earlier on people with chronic pain. And this was done by Brenda Wiederhold and colleagues, and they've done a stack of work in this area. So for example, here they used again, same as what we're using, some nature environments with relaxing music. And they showed significant relief in subjective ratings of pain. And here you can see when they just focused on the pain as the control, the average mean pain between subjects was about 5.5. When they were using the virtual reality, it went down to just under 1.5. And this is pretty much what we found as well. If people are coming in with a mean pain rating of about 5 or 6 out of 10, this is the same as that we found. But Brenda Biederhold also included some more objective measurements here, and that was heart rate and skin temperature. And these corresponded, I'll just move myself up here, these subjective ratings corresponded with a reduction in heart rate, but also significantly an increase in skin temperature from about 85 degrees Fahrenheit to 88 degrees Fahrenheit. And this is due to the person being relaxed and the sort of increased vasodilatation of peripheral blood flow, reduced heart rate, most likely due to reduced sympathetic outflow and arousal. So again, we've got the objective functional imaging of the brain, and we also have these heart rate and skin temperature readings that show that objectively the significance of the pain reduction using virtual reality. If we now move on to, let's get myself out of the way there, onto the long-term effects. Now, there's not much work being done here, and this is something we're looking to get into, especially now that these headsets don't need a huge amount of computer grunt to power them. But it also may be used long-term, so the more you use them, the more permanent neuroplastic effects you have within the central nervous system. And this is the brain's ability really to reorganize and adapt by forming new or enhanced remaining neural connections over time. So neuroplasticity refers to, again, everyday situation like driving home on autopilot, where you don't need to use GPS all the time, remembering how to ride a bike, remembering how to play a musical instrument like piano, or switching up from traffic noise, for example, for a few minutes after standing on a busy street corner. Unfortunately, there's a downside to neuroplasticity in the other direction, and this is really where how chronic pain is maintained and the development of chronic pain. And here, neuroplasticity makes the brain and nervous system super sensitive and hyperactive to otherwise normal sensations and activities. So just like turning the volume up on a loudspeaker, if you like, normal tasks, normal movements become painful when they shouldn't be. Okay. Just going to move down a bit. So repeated use of virtual reality has the potential to induce the opposite of what I've just talked about, so more positive neuroplastic effects, where long-term VR use increases cortical synaptic activity and efficacy due to persistent stimulation of postsynaptic cells and neurons along the descending pain inhibitory brain regions, prefrontal cortex, perigenual anterior cingulate cortex, down through the periaqueductal gray and the rostral-ventral medulla, back down to the dorsal horn. And here, pain inputs are inhibited by descending inhibitory pain inputs, if you like. And if you do this over a long period of time, you get this what's called long-term potentiation. So this, in this case, it's the strengthening of synaptic activity along pain inhibitory pathways, long-term depression and weakening of synaptic activity along pain facilitatory pathways. And because of this, you get sprouting of new axons along these newly activated pain inhibitory pathways. So you get, not only do you get chemical changes along in these sinuses, but you also eventually get structural changes or hypertrophy, if you like, of more pain inhibitory regions and atrophy of pain facilitatory regions. And because of this, you get all of these rerouting of new connections, not only within brain regions, but between different brain regions that also add to this neuroplastic effect of inhibiting pain. And this diagram here is a real nice sort of summary of how neuroplasticity works prior to and after an experience that induces any form of neuroplasticity. So as I said, there hasn't been much work done in this area, but something that has been done is something that was done very recently. And this was looking at the use of virtual reality for the treatment of fibromyalgia. And this was done, I'll just move myself out of the way again. And this was done over a series of 10 sessions using cognitive behavioral therapy and support of an adaptive virtual environment. And this contained, again, relaxation and mindfulness skills within this VR. And this was done over 10 sessions over 4 weeks. And what they found was that over the 4 weeks, there was a reduction in depression. There was a reduction in fibromyalgia pain. There was an increase in positive effects, so increases in enthusiasm and pride and interest, and a decrease in negative effects like anxiety and depression. But it also helped with their coping strategies as well. And this was not only just after the 4 weeks, and here we can see the effect sizes are all pretty large. Not so much in the fibromyalgia initially, but if you look at the follow-up, again, all of this becomes pretty significant. So anything with an effect size over 0.7 is large. And for any type of intervention, this is always considered really quite good. Okay. So all of this is a sort of preliminary study. It gives all of us who are really interested in looking at this as a research area are really enthusiastic by this work. If we move on, it's also being used in rehabilitation. And here we can see this was something that was done last year, and this is the efficacy of virtual reality in reducing chronic low back pain. And here they used virtual rehabilitation sessions. So over 12 rehabilitation sessions over an hour each, and a period of 4 to 6 weeks. The treatment consisted of this virtual reality sensory motor rehabilitation, and this was provided by this sort of virtual system. And this allowed the participants to perform requested motor tasks in a virtual scenario where the participants have to reach certain levels, certain results. And the results showed not only reductions in pain intensity and interference, but also additional reductions in disability and improvements in trunk range of motion. Again, so we can see from this that the virtual reality, if used properly, can help with a whole host of different types of problems. So it's not only the pain itself, but also the rehabilitation to make them stronger in the hope that they can more cope with the demand of what they're doing at work or socially, whether that's sport or whether that's working on a factory floor. Okay, so just talking more a little bit about rehabilitation. There's been quite a lot done recently on simulated virtual reality for rehabilitation, and this has been done in the stroke, traumatic brain injury, and spinal cord injury settings. And this is more looking at motor impairments. So there are a lot of virtual reality applications used now which involve different types of body rehab, if you like. So coordinated arm and shoulder motion, bimanual operations such as sweeping or carrying a tray, body balance, holding fixed position with one leg, doing squats or doing different types of movement, making sure you're not going to fall over. And the good thing about virtual reality in this setting is that you can start early when the patient is still in bed. There are objective markers that can be used, and you can simulate daily life. And because of that, and because you don't have to go to the gym or go down to a rehab center, it maximizes practice time. So it can be used anytime, any place, anywhere, virtually. Pardon the pun. So here we can see a couple of examples of this. So body balances using wobble boards and supports from therapists. This is being used quite a lot in research especially, and hopefully more so in practice. But also here we can see on the bottom left the training how to catch and how to throw. Just moving on again to another example. And this is everyday situations. So people with strokes, for example, just going to move my body out of the way again. Here we can see there's some virtual reality innovations for relearning daily activities. So using a cooker, learning how to be careful using hot hobs and plates and frying pans and etc. Learning how to manipulate taps and turning them on and off, how to do groceries, how to unpack. And again, all of this can be started really early when they're still in the hospital or where they're still classed as inpatient. So when they go into an outpatient setting, they're more able to get back into daily life more quickly and more safely. Okay, I'd like to now talk about some of the work that we've been doing. And the first one is a study that we have in that's now been getting ready for publication, and this is looking at the ability of virtual reality to reduce spinal cord injury pain in people with spinal cord injury. So we were looking at pain at and below level of lesion, so phantom limb pain, if you like. And what we found in our study was that, and what actually, sorry, just going back a little bit, we were comparing the three-dimensional versus the two-dimensional. So we were hypothesizing that the level of presence or immersion was the key factor in reducing the pain rather than the application they were watching. So they were watching the same application on two different modes of activation. So we found that both the 2D and the 3D, there was significant pain reductions, but the 3D was significantly more than the 2D. And the effect size compared to the two-dimensional application was 0.8, so really quite good. And not surprisingly, there was higher levels of presence within this 3D environment compared to two-dimensional, and the increased presence was significantly associated with lower pain intensities. And here we can see on the bottom graph here that the mean pain at the beginning of the study was just under 5 out of 10. And if you look at the bottom one, this was the headset, the 3D, it went down to 1.4 during, and at the end was 1.9. Whereas here we can see it went down to 2.6 and back up to 3.4. So significant differences between the two. We're now just getting going with another study, and this is looking at the effects of virtual reality on cancer pain. And we've only just started doing this study, and although I can't really report on what's happening with that yet, what I can talk about is two studies, and there have only been two studies, looking at how virtual reality has helped people with cancer pain. So the first one was looking at the use of virtual reality and morphine had significantly greater effects on reducing pain compared to morphine alone. And if you look at the bottom right, this is the application they use. It's called Ocean Rift. And the other more interesting study, and this was done in Japan a couple of years ago, or last year even, and here the participants in palliative care could choose where they wanted to go. And this was really quite interesting. This is something that we're looking at developing in a bit more of a bespoke manner. But this is a good example here. So this guy here, he wanted to go back to the temple that him and his wife got married in, and he was able to do that. And if you look at the top slide, that's where he got married. And this for him not only was a great joy for him to look at, but it also significantly reduced his pain. And this is why we've decided to not only take some quantitative measurements of pain relief, but also do some qualitative research with doing a semi-structured interview afterwards to get their thoughts on what they thought of when they were inside the virtual environment, what emotions did it trigger. And I can talk about one or two patients that we've had so far. One was an American who then lived in Australia, and he used that mountain scene that I showed you earlier, and it reminded him of being back in Ohio fishing in the streams, and he got really quite emotional about it. And for him, he became really happy because of that, even though he was in a terminal, he was in palliative care, and that was it. And because of that, we're now developing a study where we go out to patients and we get them to talk about what they want to watch and what they want to talk about, what they want to see. And we have developers that are going to develop a bespoke virtual environment for each individual patient. And we're not sure how it's going to work yet, but we think it's going to be, from what we've seen with these people, it's going to be really quite an amazing research study. So to summarize, virtual reality shows potential, so I just move myself out of the way, shows potential as an effective tool for many facets of medical treatments and education. Immediate VR effects on pain reduction are attributed to simple distraction due to overwhelming visual, auditory, and proprioceptive inputs. Recent pilot data now shows that virtual reality use may have benefits for longer-term pain relief through positive neuroplastic effects in the central nervous system. But further research is needed for this on the duration and the dosage necessary for long-term pain relief. So for all you budding researchers out there, hopefully I've given you something to think about. We've used on our studies, everything is commercially available and it's not expensive. And even if you get a really small grant, it's something that's pretty doable. And on that note, I'd like to say thank you very much. And if you really can't afford it, this is the next best option. Thank you very much.
All right, thank you so much, Phil, for that great talk. I certainly learned a lot about interesting ways to use VR or augmented reality as well to perhaps make a difference. We did have a question, and I also got a text, so I'm not sure if this is, if you would like to go into this more, but I believe you already answered at least part of this. But do you think that the standard games that come with Oculus Quest, like deep sea diving, have similar effects? And how might we test this in the clinic?
I'm not sure how to answer the thing on the deep sea diving because I know nothing about diving, but for me, who doesn't like water, I would probably use something similar to augment my pleasure of actually getting into the water, which is something my kids think is a disaster that I don't join them in the water. I think with my issue with Oculus is that most of the stuff that's produced by them is war game like, and a lot of it's quite violent. It took us quite a long time to find applications that were more relaxing. There's a few meditative videos out there or applications out there, but they're not that great. So I don't think there's been that much effort by the designers really to design things that are sort of relaxatory enough that for people with pain or people with stress. And that's why we've decided to go in this future study to do something that's more bespoke for the individual because there's not that much available. However, having said that, if you're looking at long-term relief of pain or stress, whatever, these gaming videos are quite good for that because it gives you some sort of competitive edge to get better and better and better, and it increases your interest, a bit like being addicted to a video game, again, like my kids are. And the more immersed they get, the less symptoms they should have, really. And if you keep using that over a period of time, then that should help. There is actually a deep sea application on the thing that we were using, but no one liked it, so we didn't use it.
Was there any feedback on what they didn't like?
Well, the virtual water was quite murky, and there was a lot to see, but it was very difficult to find. So there was whales, there was plane wrecks, there were dolphins, sharks, but you didn't know which direction to go in to find them, and that was a lot of people got frustrated with that.
I can totally see that. I feel more anxiety if I don't know how to get to where I want to go. So that wouldn't be relaxing for me, even though I love water. Okay, so another question. Is there a list of resources, brands, or products that people can refer to, or perhaps that you can recommend?
So for the headsets, the Samsung do one, Oculus do one, and I think HTC do one as well. And within those products, you have their own applications. I think Oculus have probably the broadest range of different applications, even though they're a bit too competitive in relation to what we want to achieve. But I'm not sure on the clinical education. I mean, we had to do a lot of searching online for that sort of stuff, and I think you'd have to look at the research that's out there and then write to the authors to see how they acquired their applications or who designed them.
Awesome, thank you for that. We do have another question. It seems like we could create a graded transition from virtual reality to real reality to facilitate some carryover. What do you think?
Well, I think that's that's sort of the inevitable aim, really, is to get off virtual reality and make it more real. And again, you can't use this stuff forever. Just like we aim to get patients off pain medication, you don't want to do it forever. So whatever form of self-management you give the patient, there's something where the aim is to get them into real life situations without managing normally. So I'm trying to think how you could do that from virtual reality, and I'll just go back to the presentation where if you use it over a certain amount of time and you have this long-term potentiation of pain inhibitory pathways, the less you'll need to use it, to the point where you don't need to use it at all, is what I'll say for that. I hope that answers the question.
I think that was pretty good. But then, so I have a question about, so you can see some changes in these descending inhibition of pain. How long have you tracked people in the studies? Like, how long does it last once it starts to happen?
Well, we've only looked at short term, and we have found that the distraction effect lasts for a maximum of about 10 minutes on a one-off use. We haven't gone any further than that at the moment, but from the stuff I showed you in the study, there's 1 or 2 studies that have shown that after 6 weeks, there's still a significant pain reduction, which is really good for us. And we've just been given 14 headsets and computers that we can gift to participants. So we're looking at designing a study where we can just give it to them and they can keep them on the proviso they take part in our study. And now we've got a good chance of doing a more long-term study. 6 months plus is what we're aiming for.
Well, that would be amazing. And as far as I know that studies, it's funny, 6 months in the looking at an entire life isn't that long, but in studies, to keep track of people for 6 months and to get them to participate for 6 months is a huge undertaking for sure.
And that's the difficulty, and that's the protocol I'm writing at the moment, is how do we engage with them on a daily or weekly basis to make sure that they're doing it.
I think a VR system that they get to take home with them is not a bad place to start.
It is, but it's not the headsets, where it's not the Quests, it's still the Rift. So it means setting up a big Alienware laptop, sensors, and a whole sort of thing. And some people might not have the space. It's a bit clunky, is what I'll say. But it's free.
Good place to start. Yeah. Okay, so we did get another question. Do you think there's a risk with using this type of technology with those who have vestibular systems or sensitivity to motion sickness?
Good question. We did a lot of research into when we were developing the spinal cord injury study on which types of application give you motion sickness. So what we found is anything with any form of pitch and roll. A roller coaster is a good example. We've got a good roller coaster VR, and most people don't finish it because it makes them feel really sick. So the NatureTrex application we used, there was no pitch and roll. It was just backwards, forwards, side to side, and we had no motion sickness reported in that. Whereas we did the pilot for the roller coaster, nearly everyone felt sick and dizzy. In the cancer pain study, we've had a couple of people who felt a bit nauseous, but that's because they're in the advanced state of disease. They're on loads of different types of medication, and it's the medication, it's the mixture of the medication and the VR that makes them more sick than people who are on steady courses of medication.
That's fair. And I'm so sorry. Go ahead.
No, that's all right. I finished.
So I was wondering, so you said you looked at these, so who tested all of these out? Did you actually bring in participants, or did kind of the research team sit down and play with all of these to see how they felt?
I dragged everyone in who works in the same building.
That is awesome. Come here for a minute. I have a favor. Just let me know if you get sick or not.
Yeah.
So could you tell us, I mean, without sharing too much, the protocol that you're working on now, would you like to share anything else about that?
The long-term study or the cancer pain study?
The long-term one.
Well, I've only just found out about 2 weeks ago that we've got access to these virtual reality headsets. So we've got two areas we might want to look at. So it's people who are still going to be around in 6 months, which is important. So we're looking at cancer survivors. So people who've had cancer and they've got ongoing chronic pain due to the cancer, and that's something that is really quite attractive to us. And we have the director of pain medicine at one of the hospitals near us. His speciality is cancer survivor pain, so we're going to hopefully liaise with him. Otherwise, I'll go back to the spinal cord injury participants that we had before. We have a big database of spinal cord injury patients, and they're always willing and able to volunteer for this sort of thing. They quite enjoy it. So those are our two main options.
Wonderful. And then at least one more question, but we have another one from the audience. Do you take any measurements like heart rate, respiratory rate, to track physiological responses while using the VR?
We haven't done any heart or respiratory, but in the spinal cord injury study, we're working on another paper, because we also used EEG. And so while they were using the VR, we measured brainwave patterns in people with spinal cord injury pain. So people with this neuropathic phantom limb pain, there's something called thalamic dysrhythmia, and this is a change in brainwave pattern in people with spinal cord injury. And without giving too much away, we've found that this sort of thalamic dysrhythmia normalizes during virtual reality. And this is what we hope that explains the changes or the improvements in or reductions in pain intensity in people with spinal cord injury. So that's the physiological measure we used.
Whoa, that's really neat. That's really cool to actually see changes like that.
But we're still working on the data for that.
Wonderful. Well, I can't wait to see that paper come out. Okay, so you work primarily with people who have cancer-related pain or spinal cord injuries. Have you done work like where do you see VR going maybe in the future?
As regards pain or generally?
Generally in regards to healthcare.
I think medical education is going to be it's going to become huge. I think in the mood or the psychology area, it's going to become pretty big as well. I'm in talks with some people in an institution near us who are interested in using their metadata on cell mutations in people with cancer and looking to generate three-dimensional objects to use in augmented reality as a form of clinical education for oncologists, as a good example. So in the medical field, I think there's a huge area or a huge range of applications where VR can be used to help the clinician help the patient, or give the clinician a better understanding of how the disease affects the patient or the condition affects the patient and how to manage them more efficiently.
Very cool. That's a lot to think on. Again, especially since I've never really done it before. That if this is going to be a part of stuff in the future, I might have to get over my, I don't even know if I call it resistance, but we'll have to see what happens in the future.
You just got to know someone with a headset. That's all.
I will work on that.
Yeah.
Okay, so there are no other questions coming in. So I think it's time that we can head on over to the Zoom room where the backstage pass holders will be, where there can be ongoing discussion. And then everyone else, I apologize, I do not have what is immediately next, but do stick around for later for our final speaker of the conference, Tasha Stanton. So yeah, so we'll see you in the Zoom room, and then We'll see everyone back here at 6:30. Oh, nope, I always get that wrong. At 7 o'clock Chicago time, 6:55 for the intro. So we'll see everyone soon. And backstage passers. Oh, I just got the news. Mark Milligan's doing telehealth at 3:30 for everyone who would like to head to the Zoom room for that, but not till 3:30 because we're going to be in that room for a bit ourselves. 3:30 Pacific, 5:30 Chicago. I don't know anyone else's time. Sorry. Okay. So Phil, we'll see you over in the Zoom room. Everyone else, we'll see you soon.